Well, welcome everybody. We're excited to get started today. Joining us today, we have Leanne Boyd, who is a founding partner and chief executive officer of Southern Scripts. Leanne has about 2 decades in healthcare with a specific focus in pharmacy. And today she's going to be talking about pulling back the curtains on PBMs. Leanne has held a number of board seats, including the Louisiana Drug Utilization Review and the American Pharmacist Association Policy Committee. Prior to Southern Scripts, she was director of pharmacy for Beyond RX, so we have a true expert here in this topic. So thank you so much, Leanne, for joining us today and talking about this really important topic. So I'm going to hand it over to you. A couple things before I do, just a reminder to all our participants, we are recording this. So if you choose not to be recorded, feel free to jump off. And feel free, we will all be watching the chat, so feel free to type in questions along the way. And we'll also have a Q&A at the end of the session. So wherever you want to ask questions is fine with us. So take it from there, Leanne.
Great, thank you, Jennifer, and thank you to the Clark and Levy team for allowing me to share this topic around PBMs. For the general population, PBM or pharmacy benefit manager is really an unknown. It's something that is happening behind the scenes, and there's not a lot of great information about what a PBM is, how it functions. And so hopefully after our time together today, pulling back the curtain, you'll have a little bit of information and knowledge about PBMs. But most importantly, we'll talk about some of the revenue structure behind PBMs and how all that works. It'll make you a little wiser purchaser when you're looking at PBM options as well. And certainly look forward to answering any questions that you may have. Really want to make sure you get a lot out of this, so please don't feel like scared to ask any questions. Trust me, I've heard them all and enjoy entertaining all conversations about PBMs. So with that, first, I thought I'd start by defining a little bit what a PBM is, what's the purpose. And you can see on the right-hand side of the screen, we kind of call it the wheel. And self-funded employers of health plans, you have all these different components as part of your plan, from a TPA, stop loss, and so forth. Well, you do have a component that is managing and administering the pharmacy benefits for your members, and that is the PBM. And PBMs started doing those standard administration services that I've listed here on the left-hand side. We electronically adjudicate claims, we manage all the eligibility, we make sure your members have access at pharmacies, and then pharmacies give good and fair, reasonable pricing to you all. And then evolved into some management around formulary and clinical type programs. The PBM's also running a help desk or call center for members, pharmacies, providers, working to get medications for your members. And so on the basis of what a PBM does for a plan, those services are fairly standard at the core. Pharmacy benefits is an important piece to get to know and talk and engage in more and more, because prescription benefits, pharmacy costs are all rising to be key drivers of overall health expenditures. We see across our block almost up to 50% of your total healthcare dollars are being driven by pharmacy. And certainly the #1 driver behind that is going to be around specialty drugs. And I'm sure many of you are sitting there nodding your head and know the pain point of specialty drugs. If you look at essential health benefits, you can find prescription drugs sitting in the top 3 of those. And we would contend that pharmacy sometimes ends up being one of the more complex benefits to manage. The adjudication is real time. The benefit structures, tiering, formularies, networks, all the different pricing structures can make it fairly complex. And certainly if you all have been following some of the recent legislation about transparency, PBM industry as a whole has been under that microscope with a call for transparency. We've seen the new legislation that will go into effect starting at the end of this year, the beginning of next year, where disclosure and transparency into pharmacy pricing and so forth will become a standard out in the marketplace. Many of you may be asking yourself, who are PBMs? And I've listed here some of the top PBMs by size in the marketplace. Certainly the big 3, CVS Health, Express Scripts, and Optum, capture 70% of the market based on the claims they process, probably closer to 80% if you look at dollars as a whole. And then you'll see some of the mid-tier PBMs such as MedImpact and Prime Therapeutics. And then there are smaller PBMs that make up the lower end of this chart that aren't listed here.
Leanne, is there a benefit to going with a smaller PBM?
Well, so I definitely think there are some benefits. Number one, a smaller PBM is going to be a little bit more nimble, more flexible to accommodate the customizations and the flexibility for a particular plan sponsor. I think throughout the presentation, as we talk about revenue models, I think the question that I'm posing here on this slide is figuring out what PBM that you want to partner with to ensure that there is strong alignment between your goals as a plan and the PBMs. And to me, that's following the dollars of the revenue model of the PBM. So I definitely think that there are advantages to partnering with a smaller, more boutique PBM to be able to construct, manage, control, and ensure that you have that strong alignment.
Great, thank you.
And as we segment into that part of the discussion, you'll see a quote here. There's a survey out there that was conducted called Toward Better Value. And given everybody homework, go Google that. I'd be happy to send you a link to that survey. There's a few things that I've sprinkled throughout the presentation today referencing that, but it has some great observations and conclusions that was made. And one of which is that there seems to be a disconnect and a gap between how employers, self-funded plans feel that there is strong alignment with their PBM. So that's kind of the theme of how we're exploring and what we're unraveling today. But would encourage you all to also explore that survey and its conclusions. So I have mentioned that many of the big 3 PBMs, most of the market is way more on this traditional type of PBM. And we talk about 2 types of models, traditional and pass-through. And if you look at this spectrum, on the very far left-hand side is what we're calling that classic transparent PBM. I'm sorry, classic non-transparent traditional PBM. So there's much more spread, there's much more retention of rebates, and we'll dig into some of these details. And then as you follow along that spectrum, you'll see more and more transparency evolving in the PBM model. And on the far right-hand side is a fully transparent pass-through model. No spread on network, and every bit of the rebates and they're back to the particular client. Certainly, there are versions of PBMs that fall in the middle of this spectrum. We could call that a hybrid. And you can also have PBMs that play both sides of the spectrum and every level in between, offering a traditional spread model PBM versus a more pass-through transparent PBM. But wanted to make sure you had some clarity around when we say a traditional PBM and a pass-through PBM, what that meant in terms of the revenue model around spread and rebates and other revenue streams that may not be as forthcoming to that particular plan.
And if we were to ask the question, are you a traditional PBM or a pass-through PBM, would most of the PBMs understand that question?
Absolutely. They should
Okay.
understand that question. And then you can also dig in a little bit to, and transparency has been kind of that keyword that's been tossed around, and it has different definitions to everyone. Digging into them fully disclosing and sharing their revenue model with you is the key. And our definition here at Southern Scripts of what is a transparent full pass-through PBM is one that at the PBM, we're defining our revenue source solely on admin fees. No spread on rebates. I'm sorry, no spread on the network discounts, and no margin off that rebate piece as well. So digging in a little further to ask them to also define their definition of transparency, or having your definition of what's transparent as you are the purchaser of PBM services, and asking if your definitions align would be an important piece.
Great.
This slide again was taken from the survey that I was speaking about, and it's just consistent to what we're seeing in the marketplace. As employers become more sophisticated buyers of PBM, they're demanding more and more transparency of the PBM, and you can see how satisfaction actually was found to correlate with the transparency of their PBM partner. On the left-hand side, those that aren't at all transparent had a lower satisfaction score from the employer sponsor, whereas those that were completely transparent had the higher score. So again, it just is relating what the mindset and the wishes and the desires of those employer sponsored plans are looking for and gravitating to with their PBM. So let's look and dive into how PBMs make money, what's their revenue source. And these are all things that after falling into the PBM space over 12, 15 years ago, have been learning and seeing and finding, and things evolve as well. And we're seeing new ways that PBMs are creative around that generation of revenue. But happy to share, and I think you'll have a few aha moments as we go through the next few slides. Most of this is geared towards that more traditional PBM, and certainly along with sharing their approaches, also going to offer you suggestions on how you can guard against these practices if they run afoul of what you think is the right alignment for your plan. So starting at a very high level, this is showing all the PBM revenue levers that, and bucket into some big buckets, from spread margin, rebate retention, specialty mail order. And you can see my chart's getting pretty dated. If you follow the years along the bottom axis, goes out to 2016. But if you project forward, you can see the green portion of this graph around specialty drugs gets to be bigger and bigger and bigger. You can see the significant part, how mail order, and many PBMs own their own mail order, and you can see how over time it's changed some in the revenue it generates for the PBM, but it is significant dollars as well. And so we'll dive into each one of these little buckets a little further in the conversation. But there also the thing to note is in a traditional model, if you become a plan sponsor that really drives around how you want transparency in your retail generic claims, they have other levers that they can adjust to make sure this revenue gets distributed everywhere. You can call it whack-a-mole, where if you figure out how to fix rebate retention and how that creates misalignment, something else is going to pop up. Or you may have heard the balloon model, where you squeeze the balloon on one end, it's coming to shifting to the other side. So just be aware that you cannot look at one piece of a PBM's model and feel like you have the right alignment. You have to look at the total financial equation, from how much the drug is going to cost you, admin fees around claims adjudication and data management, what rebates they're going to send you. The utilization side is huge to control just the ballooning effect and seeing the cost overall of pharmacy continuing to increase. So please keep that in mind, that as you're looking at this, if you fix one thing, you have to be aware it could pop up in another section of your PBM arrangement. So let's jump in and define a few of these things for you. First is spread. I've mentioned it a couple of times, and one of the basic core ways a traditional PBM will generate revenue is called spread. Simply put, they will pay the pharmacy one price and then charge the employer a different price. So with simple math, they will pay the pharmacy $100, turn around and charge you, the employer, $120. That markup, that spread, that 20 bucks is hidden. You don't know. It may not happen on every claim, but it will exist in that traditional spread PBM model. I've actually illustrated it here for you. If you're familiar with what's called AWP discount-based pricing, that's the typical way PBMs price drugs in contract with pharmacies, and then also on the other side, contract with you, the employer. And so AWP stands for average wholesale price. It's the sticker price, just like if you went to shop for a car, there's a sticker price. AWP is the sticker price, and you never should be paying AWP. There is always a discount off of AWP. And what happens to create the spread is the PBM will pay the pharmacy based on a more aggressive discount. So in my example here, we have a drug with a sticker price of $200. The pharmacy is contracted to give an 18% discount, or $36 off. This ends up creating where the PBM pays the pharmacy $164. On the other side of the equation, before the bill gets sent to the employer, the PBM has contract with the employer. In my example here, the discount now is only 15%. And so this allows the PBM to charge the employer $170 or create that $6 in spread revenue. That's a basic example of spread. And then a lot of what builds on the revenue model in PBMs now take that basic spread model and build and figures out, how do I continue to maximize spread and make that $6 even more? And we'll keep exploring that. The chart on the bottom, though, is showing how spread can significantly add up. And this was part of what was found with Ohio Medicaid and their PBM partner at the time. And you can see, if you go all the way to the right-hand side, spread cost Ohio Medicaid for that year $225 million. So those $6 can add up significantly to create a lot of spread for the PBM. Notice, though, a good bit of spread margin was found in particular in that generic bucket. So keep that in mind. So moving into how do they end up maximizing that spread, one game that gets played is something called NDC switch. And I saw this even 2 weeks ago when we were working on a case and found where the PBM was paying the pharmacy on one NDC, which was a generic NDC, and then they switched the NDC by the time they billed the employer, and it caused a significant change in the pricing that the employer paid over what the pharmacy paid. So to walk you through this example, NDC stands for National Drug Code. Think of it as a social security number or product code for a particular drug. And every drug, down to the manufacturer of that drug, has their own specific 11-digit NDC. And in this example, we have the pharmacy being paid off of the NDC they actually dispense at a 70% discount, which is around $1,700. But then the PBM switched the NDC to one of the more expensive NDCs that a manufacturer makes, and then billed using that higher sticker price, almost double, with that $10,902. Still apply the same 70% discount, but you can see here how over $1,600 of spread revenue was created by switching that NDC. And the bottom half of this slide is showing you how there are, for this particular generic drug, 17 different NDCs, and you can see the sticker price on a per tab basis or for a count of 30, the variation here. So the low end, $185 a tablet, the high end, $395. So it creates that big swing, and the PBM can use that in their advantage when they go to bill the employer. Ways you protect against this is certainly pass through. Number one, require that every bit of the charges paid to the pharmacy are passed through to the employer. There's no markup or margin. But even further than that, you can make sure you're only billed on the actual 11-digit NDC that the pharmacy dispensed to the patient. And there is no billing with switched NDCs. There's no billing with 9-digit NDCs. There's no averaging out these AWPs across the board and billing you off the average. Ask and require your PBM to only bill you based on the actual 11-digit NDC that was dispensed to that patient by that pharmacy.
Really interesting.
Yep. So similar to that, with us switching in the NDC, I was showing an example of switching from one generic to even another generic NDC and the variation between pricing. But it also happens with switching between brand drugs and generic drugs. And so this is something else to watch for in your contracts, especially if you bought a contract based on the network discounts. PBMs will use this to be able to, I call it fluff up those discounts, and by defining that brand drug and being able to move it into a generic bucket. And you can see some wording here as well, where it can be simply as we're going to define brand drugs based on our proprietary algorithm. A brand drug is a drug that is not a generic, and then they go on to define the generic drug a little bit more loosely. And the bottom one's great. We're going to define a generic drug from the drug attribute source and PBM standard policy. If it won't matter as much if you're not buying on network discounts, but if you are, be aware that this is how shifting drugs from that brand and generic bucket can help impact your ultimate discounts, allowing them to create more spread in between as well.
So oftentimes I've heard people say that the generic doesn't work as well as the brand name. Is there sometimes maybe a different formula? Is that why they have a different code, or kind of maybe that's too much of a sideline, but
no, I think it's a great question. I think generics, I would say 98, 99% of the generics are going to work have the same efficacy as a branded product. There is a small percentage of those products that have more of a narrow therapeutic window, and I think about blood thinners or seizure medications or transplant medicines, thyroid medications that have a little bit more narrow therapeutic window that they have to work within. And so it may be more about the patient establish a good therapeutic level on one product, and if you do the switch, it could cause some changes, and there's a process to reestablish that effectiveness on the new product. Generics should be exactly the same as far as the active ingredient. They could have a different binder or filler that maybe could be less tolerable for a patient, but by and large, they should be the same across the board. There's certainly classifications around equivalency, and the PBM should be putting in those safeguards to only allow the highest equivalent generics be replaced and substituted for the brand. I haven't seen that as a problem from the PBM industry and allowing lower efficacy generics to slip through, or pharmacies practicing in that manner. So I don't see it as a big problem. I think there's a lot of generic adoption. We see our plans performing 86, 87, 89% generic utilization, but there could be those unique cases where a patient has a different therapeutic reason, needs a brand, and your PBM should be able to work and accommodate those opportunities. The 9 out of 10 times the generic works fine, you should be promoting a generic first program.
Great, thanks. Yep.
Great. Okay, so more ways that a PBM can work behind the scenes to influence that spread margin, and this is that reclassification where they are moving. The top one is showing where they're moving from the generic version of the drug and billing it as a brand to the employer. So you can see the discount under the reclassification at 70%, paying the pharmacy $30. You move over to the employer side, they now bill it as a brand. The employer pays the 15% discount, getting the charge of $85, creating that revenue of $55. The other thing that can happen in this scenario that I was speaking to shortly above is that perhaps they do pass through the 70% discount, the $30 PBM charge to the pharmacy on the left-hand side, but instead of counting that in the generic bucket, they will count that in the brand bucket. And because they just picked up 70%, and they guaranteed you a 15, 16, 17% discount on brand, they're able to fluff that up with this big win on this generic drug that they're now coding as a brand for the purpose of your discount guarantees. How they also do that further is with zero balance due claims, which is listed below. And that's when your plan design will cause a member to pay the full cost of the drug. There is nothing due from you, the plan. There's nothing due from the PBM to pay the pharmacy. And you can see here that the total drug cost to the pharmacy for this drug was $30. The member's copay based on your plan design was $30. Maybe they were still in the deductible out of pocket. So you, the plan, owe $0. In these cases, a PBM could now count this as 100% discount because you, the plan, got charged $0. The member paid the full cost. So again, if you are bought into the network discounts as your point of purchasing, they can use this to say, hey, we've met our guarantee to you by using several of these claims that they're counting as 100% versus actually showing the cost we paid the pharmacy was 70%. So again, adding that cushion. Ways you to protect, again, if you ask for pure pass-through pricing, and also you require that zero balance due claims do not get counted as 100%. I've also seen some plans will carve out and say, we just want to toss out all zero balance due claims. And as far as the calculation, which is okay, just make sure that if they do that, they still have to honor the best price to your member. Otherwise, they can end up charging your member whatever price they want to charge in these scenarios. And you may have heard of the gag clauses that pharmacies have that they can't tell the member when they're being overcharged. This is when some of this comes into play and has been more and more relevant as we get into high deductible health plans. Clawbacks is very similar in that the cost of the drug at the pharmacy is lower than the copay. The pharmacy is paid those dollars. The member's copay is still charged, which is above the cost the pharmacy is owed. The pharmacy is required to send back the difference to the PBM. So in this example, the pharmacy was owed $30 for the drug. However, they were required to collect the $75 member copay, and the PBM clawed back from the pharmacy the $45. So this can be a hybrid form of what they'll speak to as pass-through. So you want to make sure your PBM is not practicing clawbacks. Another term for that is DIR. They're not charging all these strange fees on the backside to the pharmacy to allow the PBM to claw back dollars. For those of you that have seen the discount cards in the marketplace, you know this is the same logic a discount card uses to those cash paying cases. So be careful about how much is being clawed back. And the member it's coming out of the member's pocket, which is the unfortunate part of it.
Would one of the discount cards be like a good RX? Is that what you're talking about?
Yeah, okay. Yes, exactly. Yeah, all the and I don't think that is a big hidden secret. I think that's very, but it's just not known down to the consumer level. Many of the plans that are looking at discount cards, just be aware, and if you go that direction for your members or plans, certainly watch out or get some understanding of how much is being clawed back from when that member pays that pharmacy, and decide if it's fair and reasonable for the services that you're receiving. Right. Rebates is a huge topic. Rebates is a significant portion of the dollars, and many times it's kind of that shiny object because it is such a big dollar that attracts and drives some decision making of the plan. Certainly be very careful about rebates and making a decision purely on rebates, again, put all the components of the financial equation together and see what the bottom number is. And that's what this quote is saying, is it has become a little bit of a distraction into what drives the real value behind lowering pharmacy cost. Remember that rebates are paid by manufacturers that are trying to shift market share to their branded product. And the more market share that they're able to capture, the higher the rebate dollars get. The larger the rebate dollars, you better be certain, the larger the price tag on the drug from day one. So how do you generate more and more rebates? You drive up the more expensive medications and you drive market share to one product in a therapeutic class. So be aware that that's what's going on to earn you a large rebate. You should still go out and capture as much rebates as you can, and certainly push and try to demand more and more of those rebate dollars go to you, the PBM. Again, if the PBM is generating revenue off that rebate, they may be misaligned and may be encouraging the utilization or not discouraging the unnecessary utilization of these more expensive medications. Certainly specialty drugs have a very high rebate tag that goes along with them. And this chart is saying that there is more and more rebate sharing down to the plans, which is a positive trend. However, it also shows there's a significant bucket that still sits out there that is not going back to the plan sponsor. Here are some ways that rebates, there can be some gamesmanship around rebates as well to be aware of. First is that steering I just talked about. There is the motivation to put those drugs with the higher rebates alongside their higher prices on the formulary, encourage that utilization. You may even have seen where some of these branded products are encouraged over the generic counterpart. And that's what the equation is showing here. A brand Gleevec gets a $1,000 rebate, $4,000 net cost to you. The plan, the generic version gets no rebate, but is a $600 net cost. Why would the PBM encourage to use the brand Gleevec? It's to get that $1,000 rebate. They've promised you, the plan, some rebates, certain level of rebates, so they have to make sure they deliver on that. And they are also, if they retain 80% of the rebate, they just earned $800 under that branded version. On the bottom two, the reclassification is similar to what we talked before, but this is where, because it's a brand drug and earning a rebate, and they may actually reclassify it as a generic, and when they go submit your claims to you, so that way they can retain a fuller portion of those rebates generated by the branded product. And then lastly on this slide is what we call cherry picking, where they will pay rebates on certain claims. It may carve out, we'll only pay you on retail and mail brands, but we're not going to pay you on specialty. We'll pay you all rebates, including specialty, but we're only going to pay you a special rebate if you fill that specialty drug at our specialty pharmacy. So be very careful on how they're defining, and make sure you get a full logic tree on what claims are rebatable and you're going to receive those dollars versus which ones the PBM will be retaining. The devil's in the details when it comes to rebates. And then lastly on rebates, be aware that we all use the term rebates in this very generalized fashion. And again, the devil's in the details around how rebates are defined. And one thing that we've seen evolve is where rebates were defined very exclusively. And then other manufacturer dollars exist. And I'm showing here a chart showing you the rebate amounts, showing what's called the admin fee. So, excuse me, so defining that those dollars as an admin fee, puts it in a different bucket outside of rebates. And then there's something called price protection, also in a different bucket. So looking at how your rebates and what portion you get to share in is defined, asking, what do you do about the manufacturer admin fee? What do you do about price protection? Are there any other buckets of manufacturer dollars? And making sure you are comfortable with how your rebate arrangement is set up behind that curtain. Here, this shows how rebates were only 26,000 out of, if you follow the far right, $8.8 million. So if your contract said you only got rebates, formulary rebates, you would get 26,000 or less than 7% of the total rebate dollars that was available around this product. You may also see some reporting out there about gross to net pricing, and this bottom chart illustrates what has happened with insulin prices over the year. And you can see the blue line is showing the final price to the manufacturer. And what's interesting is it stays pretty steady. It doesn't increase a whole lot. But the red line is the price out in the marketplace. That's what's getting sold. That's what you, the plan, are paying on, is that red line. And the difference between the red line and the blue line is called that gross to net bubble. And the question becomes, what happens to those dollars in the middle? They're not going to the manufacturer. You're paying them. Where do they go? And I would contend that a large portion of that is that rebate dollars, and they're significant. They definitely influence the rising price of drugs, and making sure you're getting your share of that, but also discouraging that practice of buying those products based on just generating a rebate is what has to evolve to see this whole correction in rising prices being driven by the rebate scenario. Lastly, I'll hit real quickly on mail order. The mail order, as I was sharing before, was a significant portion of a PBM's revenue when they own their own mail order. One of the things to share with you all is to also look for the waste that gets generated by mail order. Usually when I'm in a live room, I'll ask, has anybody seen this in their plan? And lots of hands go up. They've seen it. They may have experienced themselves. There are reasons why that, in addition to generating revenue for the PBM, this waste gets generated. And that's from steering members to mail order, number one. The PBMs have promoted mail order programs, mandatory mail order programs. There's the concept that a member can come fill for one copay and waive the other two copays. So it's much more cost effective for the member to go to mail order. There's some convenience factors there, but be aware that when you waive those two copays, you, the plan, are paying those waived copays. And that waived copay is not being paid by the PBM. It's not being paid by the mail order pharmacy. And mail order can be good. It can offer some pricing discounts greater than retail, but you have to make sure whoever's policing mail order is doing it the right way. And sometimes that's the fox guarding the hen house if you have the PBM with their own mail order and they're doing the guarding. One example of that is what I have here is called refill creep. So most mail orders may relax what's called the refill handler, and they'll automatically send out medication when a low percentage of a supply has been utilized. My example here says 70%. By refilling automatically and autofill, it ends up creating 1 to 2 extra fills per calendar year. That's a 90-day supply of medication. On a brand drug, you're looking at many times for a 90-day over $1,000. So it ends up generating some significant dollars just by increasing utilization. It also increased rebates for the PBM as well. The other thing we've seen around mail order that can eat away at some of the potential savings at mail order is package size. What they'll do is your contract will specifically say, we're going to bill you on a full package size of 100, even if we actually dispense a lower quantity. The most common quantity in mail order is 90. So in that scenario, you are still required to pay for a full 100 tablets, even though only 90 were dispensed out to your members. And then lastly, repackaging. When the mail order buys these very large supplies of medications, they can repackage them into these smaller quantities like 100. They also get to assign a new NDC. And remember, that's the National Drug Code. And along that, they get to assign their own AWP, their own sticker price. So many times we will see that sticker price go up versus what the original NDC would have offered. So while they're giving you a better discount at mail order, it may be on a higher starting sticker price. What can you do? Define what you want your refill handler to be. It should be 75, 80% at a minimum. And to guard against that refill creep, make sure you're not being charged on package sizes. Be charged actually on the quantity dispensed. And whether it's mail order, retail, any pharmacy, do not allow any repackaged NDCs to be part of your plan. In specialty drugs, here the main thing that there's lots of opportunities within the PBM space to really control specialty drugs. And the whole point of this slide is to see how over time, if you look at the top pharmacies dispensing specialty and controlling the specialty pharmacy side of the equations, they're all associated with PBMs. And this will continue to evolve. How you're going to protect yourself long-term is how you're addressing specialty pharmacy. That's where the big drivers of cost are. So getting very creative, putting a lot of attention and safeguards around how that is being deployed. Avoid exclusive specialty arrangements where only that PBM-owned specialty pharmacy can dispense those drugs for your members. So that way you can retain some control around specialty drug management. Lastly, this is a little bit off topic, but was something we thought we would share as an example of how do you get creative? How do you find new ways to manage specialty drugs? And we've evolved a model, we call it a walk, or crawl, walk, run, fly model. And while you have your standard PBM services that bring in pass-through on network pricing, pass-through on rebates and so forth, you still need to tackle utilization, and you still need to look to other alternative channels to source the drug other than this traditional AWP discount model. And one of the things that we found as a very effective way to lower that purchasing price is through 340B. If you haven't heard of 340B, it's a program that was made available under Obamacare, expanded the utilization of 340B pricing through covered entities or hospitals that serve a disproportionate share of the low-income population. Through a program that we've started at the beginning of this year, we've partnered with some of those covered entities, federally qualified health centers, FQHCs. They will actually help qualify a patient for the cost of a drug under the 340B program through a telehealth visit. That telehealth visit will allow you, the employer, to get some discounts. Certainly they retain some of that 340B discount to support their work that they're doing, but are now extending you the opportunity to save some dollars on those specialty drugs through this 340B telehealth program. And so in the interest of time and making sure we have plenty of opportunities to answer questions, I think I'll stop there. I think that's pretty much the information we were hoping to cover today, and happy to entertain any questions related to this information, or if there's something else you were hoping to hear about PBM, happy to answer that as well.
Well, Leanne, thank you so much. Great information. As people are typing in their questions, I'll start off with, for an employer, how do they go about negotiating with a PBM? Do they do that through their broker? Do they do that directly? What would be your guidance there?
So I think by and far most rely on the broker to help them negotiate their contract. Very important to have a thorough review of the contractual information and terms in your contract so you understand those nuances. It's also very important that you look at what is the full equation of drug cost, not just the discounts, the actual cost of the drug, quantifying the rebates, quantifying any admin fee charges up front. Many may be add-ons or charges for services like prior auths or clinical programs. And it's a lot for an employer to tease out and understand on their own. So it's very important to rely on someone that's looking at this with a lot of employers and having that broker or consultant help figure out what is the best arrangement, what is the best alignment, what's important to you, and finding the PBM that fits that alignment.
Great, thank you. That's super helpful. So I have a question here. For the consumer directly, what can they do to make sure that they're getting the best prices?
Good question. So starting with, if you are on a pass-through model, being able to, as a consumer, take a second and look at which drugs are and what price is applied to your medications at your pharmacies in your community. With pass-through, there are some chains in particular that do demand a higher price versus other pharmacies in the community. Understanding those differences, you, the employee, the consumer, would save dollars and also help your plan to save dollars as well. The plan can help by creating some copay differentials to encourage the utilization of those pharmacies that offer the best price. But from a consumer perspective, using those pricing tools to find out what that price may be beforehand. You can also call, for example, into our call center and say, look, I have these set of drugs. Please help me find which pharmacy offers the best price to me and my plan.
All right, great. That's super helpful. And then one other question here is, what options does a patient have if their prescription is not covered through their company's PBM?
Sure. So first, if a drug is not covered because of formulary reasons, a preferred versus a non-preferred or excluded, your PBM should be able to show you what the preferred option would be. We have a dynamic formulary that's specific to each client, and a member can enter that information and it will pop up the preferred alternative to a particular drug that's been prescribed. The other thing, though, that happens is more and more plans, because the burden of these specialty drugs are so much on the plan, they're electing to exclude certain drugs. It could be orphan drugs exclusions. It could be specialty as a whole. It could be certain therapeutic classes. When that happens, the opportunity to source that drug through alternative means is available. Patient assistance programs could be directly from the manufacturer. And sometimes that member has to meet certain household income requirements to qualify for that program. There is what we call international mail. You can source the drug from a different country under personal reimportation laws. It's up to the individual plan how they feel about that. Certainly there is some debates on both sides around reimportation. There are some granting organizations. And then at Southern Scripts, we work with a host of different, we call them overlay programs, or vendors in this space that will assist your member in qualifying for free drug or greatly reduced drug through this different channels and sourcing that drug off the plan. And so overlay programs is another alternative to consider if you're looking at excluding for certain therapies.
All right, excellent. Well, it looks like that's the end of the questions. Again, I can't thank you enough. I think this was super eye-opening for me, and I'm sure it was for our attendees as well. And I really appreciate your time and all the information today.
Thank you very much, and always happy to entertain questions even after the end of this event. But thank you for the opportunity to talk a little bit about PBMs.
Great, thank you. And thank you to all our attendees for joining us today. I hope you had an informative hour just like I have, and we look forward to seeing you at our next HRX.